First question. These questions are prioritization questions, and I want you to be comfortable. There's an easy way to approach them. As you've watched all my video, you have to divide a question into two and ask yourself, is this a B-sharp moment or unexpected finding? Therefore, how do we approach this? 65, age does not matter. Aortic stenosis, what should I expect? Syncope on exertion, is that what I should expect? Is this problem worrisome? Is it part of the B-sharp? We have a patient, stable angina, report chest discomfort on climbing the stairs. Is that something you should worry about? We have a peripheral artery, disease, PAD, who reports severe pain and power when the leg is elevated. Is that unexpected finding or B-sharp moment? Do we have hypertension patient who report occasional dizziness? And then you write your B-sharp and you said what? Is any breathing, electrolyte shock, sepsis, airway, and pain, and that I should worry about? Oh, if you have hypertension, occasional dizziness is bad, but that's not the priority. PAD, if you elevate your leg, it's going to hurt. And your leg is going to look power, like white. Don't worry about it. Unexpected finding. You have stable angina. Well, you're going to have chest pain. And when do you get chest pain? When you are exerting yourself, climbing the stairs. Unexpected finding. Therefore, we have only this. Aortic stenosis with the syncope is a warning sign for sudden cardiac arrest. This is how you do prioritization. Therefore, we're going to go with number one. First question down. Second question, same thing, prioritization. Which client should the nurse prioritize for additional workup? We got to do something. That means you got to be sharp and pay attention who is in trouble. The nurse assessing several clients at outpatient cardiology clinic. Once again, divide the thing into two. Find the cause. What is the problem? All the patients are on amiodarone, as you can see. Therefore, I'm not worried about it. I just have to pay attention. What is the major side effect of amiodarone? The patient taking amiodarone, it develops what? Blue-gray discoloration. Amiodarone, cold intolerance. Amiodarone, clay-colored stool, right? Amiodarone, report dry, productive cough. Oh, then I write my amiodarone. I said P-clone. That is the buzzword. When you see amiodarone, right, P-clone, that means P isn't your number one. Pulmonary fibrosis. You're going to have cardiac issue, right? You're going to have liver issue. That's why you have clay-colored stool. You're going to have endocrine. That's why you have cold intolerance, right? You're going to have dermatitis. That's why you have blue-gray discoloration. But what is the problem? If I see pulmonary fibrosis, I'm going to make you another baby, or I'm going to recreate you, and that's clone you. Therefore, this patient who is having dry cough is a bad problem. That's your prioritization. And this is assessing for client at the cardiology clinic, taking what? Nitroglycerin tab for stable angina. Once again, every question, I will give you concept and take the concept with you to answer the question. What is the concept for nitroglycerin? There's a key thing you're supposed to do with nitroglycerin. Look at the question and see, and the answers, and see if the patient is following through. A 65-year-old who patient sit down and take the tablet at first sign of chest pain. Is that what you do? You teach the patient? That's the concept when they're taking nitroglycerin. A 58-year-old places the tablet under the tongue, sublingual, every 5 minutes, right? Up to 3 doses as needed. Is that what you do? That's the way you should teach the patient. 70-year-old, he swallowed the tablet with water when he has chest pain. Should you intervene? You keep the tablet in the original dark container. These 4 concepts is what you need for your NCLEX, and I want you to write it down. Every time they give you nitroglycerin, these 4 things may show up. There's one more about when to call the emergency room guy. When you have chest pain, you take 1 tablet. If it doesn't go away, call before you even proceed to take the second one. Therefore, what is the problem? This guy is doing right thing. He take the tablet, first sign of chest pain. It's a sublingual. You put it under the tongue. You can repeat it every 5 minutes. You should know, swallow it. It's a sublingual, no water. And you should keep it in original container because it's dark. Write all these concepts down because that's what you should expect with nitroglycerin. This is our prioritization. What is the next priority action? That's the first thing you read. I'm paying attention. A nurse is caring for a client with pulmonary embolism on IV heparin. Oh, platelet count is what? 90,000. What should I do? Prioritization. Something should tell you. Decrease the heparin, change IV heparin to enoxaparin, hold the IV heparin for 90 minutes, or anticipate prescription for rovaroxaban. Bring your content. You said, oh, patient has what? Breakdown. Look for the buzzword. This is what I'm saying. Pulmonary embolism, IV heparin, platelet is going down. Connect these 3 dots. This and that, platelet down. If I give you heparin, your platelet go down. It's called heparin-induced thrombocytopenia. What is the concept? Write it down. Every time you see heparin-induced thrombocytopenia, you are not going to give the patient any more heparin. I don't care if you decrease it. I don't care if you hold it. There is no more heparin. That's the concept to answer the question. If you look at the answer, I see heparin. I cancel it. I see heparin. I cancel it. Another heparin. I cancel it. There is no heparin. I'm picking you. That is the concept to answer the question. You don't even have to think. Heparin, low platelet, no more heparin. I don't even care about the sentence I've written because it's a trap. If you follow it, you get in trap. Pay attention to the concept and write it down. Therefore, we're going to give you anything that does not have heparin in it. And that's the medication. And that's the explanation. Number 5, concept, prioritization. If you need it, I need you to click on the button right now and subscribe to Adapt in case you get more content with prioritization. This is cardiology prioritization. And nurse is caring for 4 clients who has what? Abdominal aortic aneurysm. Which client should the nurse prioritize for additional problem? They all have abdominal aortic aneurysm. Therefore, you're looking for bad things that will happen to aneurysm. What is that? Rupture. Which signs indicate rupture? Blood pressure of 140/85, but he has mild back pain. What do you think? Pulsating abdominal mass. Is it worse than the first one? He has occasional frank discomfort, and he has severe calf tenderness when walking. What do you think? Don't get trapped. Pay attention. I said be sharp. Shock, sepsis, airway. For this patient, I'm worried about shock. Blood pressure is normal. Back pain, I don't like it, but blood pressure is still normal. You are not in shock. Positive abdominal mass, you're going to rupture very shortly. Occasional discomfort, I may pair it with mild back pain. Severe calf tenderness, you having claudication because you have peripheral aneurysm. Therefore, what do you think? Classic prioritization. Positive mass in a patient with AAA, that's a problem. It's going to rupture. Who should the nurse see first? Same thing. Prioritization 101. Break it down. Look for unexpected finding, and cardiology prioritization require you to know the content, and you take the buzzword. I will show you. We'll get to some. The next kind of questions will be buzzword questions where you connect the cues to find the diagnosis. And that's what recently somebody told me they asking on the exams. So know how to find cues, put it together. What is the problem? They all 1 hour. What? Cardiac catheterization. What am I worried about? Bleeding. He went through the femoral area and there's bruising in the groin. Is this bleeding? 1 hour, what? Post large paracentesis. They draw fluid from the abdomen. I'm going to worry about hypotension. He has headache and temperature. Well, that's not going to kill him. 1 hour after post-liver biopsy, I'm worried about bleeding. His heart rate is 75. It's okay. 1 hour post-admission for pneumonia, I'm worried about sepsis, but he's getting antibiotic. And his temperature is not that high. SAT is fine, roommate. Therefore, you know he's in trouble. Number 1, he's in shock. He's going to die from bleeding. We got to see him. Did you see how I'm approaching prioritization? That's the way I want you to do that. 6 questions. The next one, select or apply heavy. Select or apply heavy. I want you to be comfortable. By the time you finish this video, you'll be comfortable answering select or apply. And I'm going to give you signs and symptoms. How do you connect signs and symptoms to diagnosis? Client with what? Left-sided heart failure. What is that? Left-sided heart failure with what? Progressive dyspnea. Which clinical manifestation will happen? What do you think? All I'm asking you, what should you expect in a left-sided heart failure? And then you write it down. You say left side heart failure, you're going to get lung symptoms. That's all. Pulmonary symptoms. To know the detail about cardiology about this, I have a video that I did. I will attach to this. It will give you the content. But the only one thing you should know, left-sided heart failure should be about your lung. Therefore, if you pick in an answer, pick it about the lung. Brachos is about the lung. Okay? Dyspnea or exertion is about the lung. JVD is the system, not your lung. Autopnea is your lung. Ascites is not your lung. That's all. Trust me, that is the way. Make the answer choice selection easy. Don't overthink it. Don't overthink any of this question. Next one. A client with acute pericarditis. What should you expect? I want you to write this down. If you're having problem with the concept, I use this strategy to create these videos, to create these questions. I take pericarditis, and these are signs and symptoms you should know. This will help you with what? Case study, select or apply, everything. Pericarditis, that means the pericardium of the heart is inflamed. You have inflammation there. There's key words that you need to know about this diagnosis. What is that? Do you have chest pain worse when you are supine position? Does the chest pain get worse when you lean forward? Do you have diffuse ST elevation? Is your pulses going to be bounding? And do you have hypotension? These are signs and symptoms. If you know this, case study will be easy. If you know this, select or apply will be easy. If you know it is, prioritization will be easy. What should you expect? Well, when you have pericarditis, there's inflammation around the heart. When you lay flat, it's going to hurt. When you lean forward, it gets better. So this is wrong. Your ST elevation, because you have chest pain, is going to be elevated. But what is it? Diffuse ST elevation. It does not affect your pulses. Your pulses is not going to be bounding. And you're not going to be what? Hypotensive, unless you have severe what? Constrictive pericarditis and you've developed what? Tamponade. And so these are signs and symptoms this patient will expect. The nurse will expect to see. I want you to master this. And you have to watch this video multiple times to know about this problem. Unless the patient develops tamponade, they're not going to be hypotensive, their pulses is not going to be affected. Number 9, same thing, pericardial effusion. What do you know about it? A client with recent pericardial effusion is being assessed for what? Tamponade, cardiac tamponade. This is a classic way you will see the NCLEX ask the question. Try to frame it like the way it is. Cardiac tamponade. The key word is not pericardial effusion, it's cardiac tamponade. Patient has pericardial effusion, that means fluid around the heart. Now they have cardiac tamponade. There is signs and symptoms of cardiac tamponade, and you should know. If I'm squeezing your heart, what is going to happen to you? Your heart sound will decrease, muffled heart sound. You're going to have congestive heart failure, and you develop JVD. Your blood pressure is not going to go high. It will decrease. What will happen? Your blood pressure will get closer. Systolic will get closer to what? Diastolic blood pressure. That is narrow pulse pressure. You're going to be what? Tachycardic. Write all these signs and symptoms down. You're going to have narrow pulse pressure. It's an acceptable finding. You're going to have muffled heart sound. If you don't know about tamponade, write this down. You're going to have congestion. You have JVD. your blood pressure is going to go down and you become tachycardic. Signs and symptoms. This is what the person said they asking. Signs and symptoms connected to diagnosis. Now you know what are the signs and symptoms of cardiac tamponade. That's the key. Same thing. A client with what? Atrial fibrillation with what? Rapid ventricular response is being assessed. Which clinical finding are anticipated? Look at it. This is a hard one of the hardest one. But don't worry, it's a select reply. Let's break down the question. You can stop the video, try to answer it yourself, and then put your answer in the comment. But this is the way you should approach this hard question. Select reply. What you should do, don't over-select. Don't be greedy. Pick those that you're confident. Which finding are anticipated? That means the one I will see. Look at the way I approach it. Patient has what? Atrial fibrillation. There's one word there. That's the bars rate. Atrial fibrillation. And he has rapid ventricular response. The atrial is fibrillating. The ventricle is also responding. Which finding are consistent? Number one, if you have atrial fibrillation, your rhythm is irregular. You don't have to overthink it. If your rhythm is irregular, if you look at the EKG, it looks like this. I can't even see a P wave. Loss of P wave. Well, if your heart is fibrillating, you can form clot, risk of stroke. Unless you have a chest pain, you're not going to have elevated troponin. And there's going to be pulse difference. Your systolic, the pulse difference deficit, right? Pulse deficit means if I look at your apical pulse, I check apical pulse in your chest, and I check your regular pulse, there's going to be different. That is what we call pulse deficit. Therefore, we have irregular rhythm, loss of P, risk of stroke, and that. That's all you need to know for this question.